everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Hi, everyone, and welcome to another episode of the Surgical Ergonomics podcast. Today, I am very happy to have as our guest Dr. Christopher Perkes. Dr. Perkes is an anesthesiologist at Trillium Health Partners in Mississauga, Ontario, Canada. His non-clinical pursuits have included serving as an Anesthesia Medical Director for Quinte Health, Premesis Inspection Committee member for the College of Physicians and Surgeons of Ontario, and delivering a Canadian Anesthesiology Society presentation on ergonomics for the anesthesiologist. Chris, a big warm welcome to the Surgical Ergonomics podcast.
Thank you, Geeta. Thank you for having me today. This is a topic that's near and dear to my heart, so I'm happy to be here.
Of course. Thank you for being here again. So, Chris, just as I do on other episodes of the podcast, I was wondering if you might be willing to share with our listeners a little bit about your background, where you grew up, where you went to school, did your residency, etc., and how you landed up in your current role.
Sure. Yeah, I grew up in Ontario, Canada. I did most of my training at the University of Toronto, where I became a board-certified anesthesiologist in 2013. So I'm now somehow in my 13th year of practice doing that. And I do work primarily clinically at a pretty high volume center, but we're not, a formal teaching center, for example, although we do have residents and students here and there. My wife, Ashley, and I have a very busy home life. 3 kids. Ben is 10. We have Penelope, who's 9, and Mackenzie, who's 7. So that's really my full-time job. And I get to anesthesia when time permits. I used to be very active with sports, golfing, paddleboarding, baseball, squash, things like that. But I had a back injury about 7 years ago. So now most of my time, I'm spent focusing on strength and flexibility training, and then just coaching my son's rep team, playing with my kids, and helping out where I can within my department at Trillium.
Okay. Thank you for sharing that. And I think we have the U of T alum, shared history, because I did my medical school and residency at U of T, and I know the structure you're describing at Trillium Health Partners in Mississauga. So,
wonderful.
Sort of university adjacent, but not full university hospital, right?
Yeah, totally. And we're in that, probably going to be take a generation, but we're in that transition phase where you can see that more and more academia is coming our way,
Exactly.
in terms of formal and informal partnerships. And so we're embracing that, of course, and the challenges that come with it, but also the opportunity that comes with it.
Right. Now, Chris, I'll let our listeners know that I was actually introduced to you via another surgeon who's active in the Society of Surgical Ergonomics. And then I also know that you were part of one of our symposia a couple of years ago in the Society of Surgical Ergonomics. Our mutual colleague is Dr. Julie Halle. And I want to let our listeners know that even though the podcast is called Surgical Ergonomics, I chose that name for a reason. I didn't want it to be surgeons' ergonomics or ergonomics for surgeons. I wanted it to be about surgical and procedural ergonomics, because we're not the only ones as surgeons working in the OR. It is very much a team sport, and we can't do what we do without the help of our colleagues, such as yourself, so anesthesiology team members, and our scrub staff, either nurses, techs, etc. So I want to make that clear that this podcast is for anyone working in surgery or procedural areas, I should say. So you mentioned a little bit about sort of your back injury. So I want to kind of ask, did your interest in ergonomics arise because of that? Or are there separate, it's just a separate injury that happened and then you happened to become interested in ergonomics because of something else? I was wondering if you could share that piece as well.
Yeah, no, my interest was purely born out of, the injury that I sustained in 2018 that actually led to me missing a year of clinical practice to focus on physiotherapy, occupational therapy, and essentially my recovery. So it was really through that process that I became interested in ergonomics, and then it became a passion of mine really when I started to see in real time how working ergonomically just so dramatically improved the resiliency of my back, both during and after work, and even into my home life. So
Yeah.
it was learning about it and then putting it into practice and just being blown away by the difference. I was aware of ergonomics, of course, and lots of wise people that I trained under over the years would make mention of the importance of doing things from an ergonomically sound perspective. But it wasn't really until I had the back injury and all these things that I used to do pain-free
Yeah.
suddenly hurt. And it was initially confounding, but then you learn why they're hurting because of the strain you're putting on your body by functioning in a non-ergonomic way. So that's where the passion
Right.
came from.
Understood. Yeah. So that kind of echoes somewhat of my own story and of other people that have been guests on the podcast, right? Like we've kind of heard about ergonomics and in passing, like maybe we were told to stand up straight or something like that. I call that informal ergonomics training.
Mhm.
And then, until we kind of experience our own injuries and start looking into it, it doesn't quite land. In that vein, I was wondering if you might be comfortable sharing kind of the details of your injury, and it's okay if you're not. I mean, was it one single event that kind of precipitated things, or it was something kind of chronic, as much as you feel comfortable sharing?
Yeah, no problem at all. I mean, this was a classic wear and tear injury. I sustained an annular tear at L5S1, and it just crippled me with pain and regular muscle spasms for about 3 years. And
Wow.
it just kept getting, it just kept continued to get worse as I tried to work through it while attempting, conventional treatments like physiotherapy.
Hmm.
It got to the point where I wasn't able to do my job this as safely as I previously could because the pain was significant enough that it was occupying a lot of my bandwidth, honestly.
Wow.
And it got to the point where I couldn't function at home in any kind of a normal way, picking up my children, engaging spontaneously in play with my children. They were no-goes for years because of the pain and the spasm. And so, it eventually got to the point where I consulted with my disability insurance provider and my pain physician, and they strongly advised me to just get off work and focus on recovery because, it's the kind of injury, given there's poor blood supply to the annulus. So it's the sort of thing that it does tend to heal on its own eventually, but it can take a long time. And in the interim, I was doing a lot more harm than good by trying to push through.
Right.
So that
Wow.
was the,
Yeah.
that was the basis of the injury. Yeah. But it was really the result of a number of years of just wear and tear, rotational, load bearing exercises, not just at work, also like, with the way I would exercise at the gym or my sporting activities or parenting or yard work. But yes, also at work, just turning and twisting to look at monitors, stooping over my patients to intubate or put in intravenous's, prolonged holding of postures like, forward flexion to put in a labor epidural, and portering patients, transferring patients, and doing it the wrong way over and over and over again certainly contributed to the injury and the progression of the disease.
Right. Right. Wow, you mentioned so many different things which, resonate with my own path, but also that of other guests on the podcast. But you also raised some unique things, which I will take a couple of minutes to just unpack here. So, parallel with my own path is that I actually also had first an L4, L5 disc, annular disc rupture, as well as then a few years later, because I didn't change what I was doing and now I was a surgical fellow, was an L5S1. And
Mm.
it sounds like you also did not need surgery, but the injury resulted in a fair amount of disability in terms of spasms, pain, and interference with activities of daily living, which was my experience too. In one way, I considered myself fortunate that I did not need surgery, but I think it really diminishes the effect that it had on other parts of my life because you have that constant spasm. For me, it was, I don't know if you felt this way, but I felt like my body below my pelvis was divided into two parts. One part was always tight because of the side on which the disc herniated, always kind of having intermittent numbness and tingling. But because there was no motor symptom or autonomic dysfunction, you're left to kind of heal on your own and deal with it because there's nothing quote unquote surgical.
Yeah, absolutely. One part of the body just didn't work properly for a
Correct.
very, very long time, and it was very debilitating. And your world just gets so small when that
Small. Yeah.
happens,
Yeah.
and that's the best way that I can kind of conceptualize it. Your hobbies that you enjoy are probably not open to you anymore. For me at that time, it was golf,
hmm
baseball,
hmm Playing with your children. Yeah.
CrossFit, playing with my children, helping my wife, as a partner around the house. And then, of course, clinically as well. I mean, I was young in my career,
hmm
at least about 5 or 6 years into my career. And I was still, well into that point where I was one of the heavy hitters in the department in terms of the
Yeah.
hours I would work and the call I would take. I was trying to establish my career and also my financial foundation. So the world just went from being seemingly wide open and limitless to extremely small. And that's very scary at any
Yeah.
age, but
Yeah.
particularly when you're in your 30s and 40s, little kids. So, yeah,
Yeah. Yeah.
absolutely.
No, thank you for outlining that so eloquently because I think people think, well, yeah, this injury happens and, as you said, it's wear and tear. And sometimes it may be hard to prove that it's coming from kind of, unless you had a slip and fall and it's an acute injury, wear and tear. But the fact is that there is always going to be an element of nature and nurture, right? Some of
Hmm.
us go through entire careers without having these kinds of injuries, but many of us have pain and these kind of injuries, and some need surgeries. And there's now good data to show that, among surgeons and at least among surgeons, I haven't seen the corresponding data for anesthesiologists, but at least among surgeons, the rate of requiring C-spine and L-spine surgeries is much higher than in the general population, right? So you
Hmm.
can't discount that work component to it. And that takes me back to some of the information you shared just kind of in that last little bit, which was all the risk factors that you shared and these are well described in the anesthesia literature, at least from what I could see. And you kind of hit upon all these risk factors, right? So your work, anesthesia providers are the biggest in sort of in terms of kind of carrying the load when it comes to positioning patients for surgery, whether, we say we want the patient prone, we want them lateral decubitus. Well, you're the one at the head of the bed and you're along with all of us and the nursing staff, but really the anesthesiologists take a lot of strain. And I've seen that even in sort of the coaching that we do. You can see the analysis of ergonomics kind of software post checker that we use that, I mean, the strain on your bodies is like right there to see. And that's just the initial part, like you said, portering patients. When you're trying to intubate, right, there are high level forces because again, I've seen this in the videos that my partner and I look at. You're pulling against yourself to do laryngoscopy, right, before you intubate the patient. And the way the work is set up, you're having to sometimes look at vitals on a monitor, again, twisting while you are applying this forward force, right? So when we put all those things together, it's no surprise that there's such a high rate of injuries, and lumbar injuries are number one among anesthesia providers or anesthesiologists. I'm including kind of CRNAs in this as well, because in the US, we have a lot of CRNAs, unlike in Canada. So then it becomes no surprise that, there's such a high rate of injury. So I guess that brings me to another piece. I was wondering if we could just kind of keep talking a little bit about your journey. Now take us back to the time where, now you've been experiencing this ongoing pain, you're trying to work. because like you said, it's consequences are on income and, you're establishing your financial security, you don't want to let down your colleagues and your patients, right? All these things come into play. So why did it take, I should say, 3 years for you to be able to kind of decide to take some time out? Like, were there institutional factors, organizational factors, personal factors, or you just thought maybe you could push through, like almost all of us think that way, right?
Yeah, a combination of all of the above, beginning with though just being young and believing that anytime I've been hurt in the past, it eventually gets better, and
Hmm.
often without a whole lot of effort. To be honest,
Hmm.
when you're at a certain age, that's just your experience. And then beyond that, my initial stages of seeking out, healthcare, you kind of follow the usual mechanical back injury pathway, some physio, that sort of things. Trust in that system. It just wasn't working, unfortunately, in my
Hmm.
situation. But I didn't know I had an annular tear at the time. You don't get imaging right out of the chute when you have back pain, generally
Right.
speaking, right? So I'd say for the first 6 to 9 months, I was just spinning my wheels, trying conventional approaches to mechanical back pain, not knowing that I had a legitimate injury back there that was going to take a long time to heal. And I
Right.
think I did a lot of harm during that time because I continued to do all the things,
Yeah.
all the things.
Ibuprofen and coffee and physio, right?
Exactly. And yes,
Right.
just learning to grin and bear some pain, it will end. It at some point it will get better was the mentality, and everybody works through pain at some point. So really it was 6 to 9 months of that with things just getting worse and
I
slowly
see.
but surely my world getting smaller because no, now I definitely could not swing a golf club. I could not ride a bicycle. I could not paddle board. Okay, but those things are fine to give up because
Hmm.
I can still get through work. I can still hold my child and rock them to sleep and put them in their crib. So you kind of just slowly but surely the world was shrinking, but I was okay with what it was going away because I was still able to do those core functions, albeit in pain. So that's kind of how that process began. But then you spoke to other factors, institutionally. I wasn't working at Trillium then. I was in a small community hospital. There was
I see.
only there was only 7 full-time anesthetists.
Oh,
So
wow.
when one goes off or needs time, it's an issue, of course. And I had very supportive colleagues, but you're doing everything you can to not be that person that needs that support. So
Right.
I felt right or wrong, I felt pressure to carry on with how I was working clinically. I was also at the time the medical director of anesthesia and surgery at my institution. So I had a heavy administrative load as well. And the thought of not being able to carry that on suddenly, that just didn't compute with me. We had a lot of sticks in the fire, so to speak, that I didn't want
Yeah.
to lose sight of. And if I wasn't working clinically, I felt like I would because so much of a job like that is relationships.
Right. Right.
There was institutional pressure, even though no one was directly pressuring me. I felt it on my own accord. So that's really why it was about 3 months to kind of heal. It was about 19 months before I actually took the advice and went off work. So it was a year and a half. And if you throw it, then the other monkey wrench there was COVID, because
Right.
the injury was late 2018. I started thinking about going off work basically, 6 months into COVID, at
Hmm.
which point it was challenging to even get the services that you're looking for in terms of physio, occupational therapy, uh, you know,
Right.
chronic pain providers, that sort of thing. So a lot of factors, but most of them were internal factors with
Hmm. Hmm.
just really being hesitant to accept reality of what I was dealing with. And I would say that was one of my biggest takeaways was in our profession, there's no sick days, there's no structurally built-in opportunity to really look after yourself when crisis hits. So it's a bit of an obstacle, but it's one that we have to be prepared to overcome, and prioritize ourselves when the need arises.
Yeah. Yeah. So many different layers, as you mentioned. For our listeners who might be just tuning into this podcast for the first time and happen to land on this episode, I have to tell you that Dr. Perkes' story is not unique. This theme you will see in every episode, doesn't matter which specialty the surgeon or the nurse or the tech has been in. and of course for anesthesiologists as well, because there is this thing that I call procedural culture or surgical culture, right? Whether I think some of it is ingrained and then it's reinforced over and over again, right? All of us literally feel responsible for the system functioning, for not letting down our colleagues, our patients. It's a lot of personal responsibility when the responsibilities should be really split because thinking about ergonomics, really, it is a systems issue, right? It is about protecting the workforce. But that has never sort of been looked at before because healthcare workers in general don't talk about these topics. These are taboo topics because you're worried about what will happen to your practice, what will happen to your livelihood. What will people think? You're too weak to be a surgeon or an anesthesiologist. And so many different things play into this, which then kind of results in delay getting care. Of course, there are external factors, like you mentioned, COVID, etc. But there are so many of these internal factors that we really should talk about. And I'm so grateful that, you're here, and I really appreciate the fact that you're willing to be open and vulnerable about the things that you were thinking about at that time. I think that will go a long way to reduce some of the stigma and some of the shame that people feel around, being injured at work. So let's continue on this journey, and perhaps now that you are eventually back to work, I want to sort of hear from you, and I think our listeners will as well. What were some of the things you learned about yourself and system things that you wish you had known then, good and bad? And what is it that you now try to incorporate into your work and perhaps teaching trainees, if and when they're around, or junior colleagues about how they can take care of themselves while at work? So two
Sure.
parts question. Yeah.
Yeah, I think as it relates to what I do at work now and just bigger picture,
Mm-hmm.
one of the big challenges is that we work in the operating room, we're working in a shared space,
Mm-hmm.
and we're not working in the same operating room at the same time with the same people very frequently. So it is a challenge to standardize that work environment, and it is a challenge day to day to advocate for what you need to work ergonomically. You feel
Mm-hmm.
like you're almost a visitor, every day in the operating room, even though that's where we work as anesthetists the majority of the day. We're still kind of visitors. It's not the same as setting up, your surgical clinic, for example, where you are the surgeon, I'm presuming, who is in the rooms with the patients every day. You can set it up to your own specifications. And
I hate
so,
to break it to you, Chris.
yeah, no,
No,
not even.
we don't
Okay.
we don't even we don't get that same luxury in the
Not
OR as
even.
well. Sometimes I feel like I'm a visitor in the operating room because I think
Oh,
of the environment that we're in. It's different. You're not working with the same people all the time.
oh no,
Yeah.
I completely understand. I mean more like if you have your clinic, for example, as a surgeon. But maybe I'm envisioning, when I go to see my optometrist and they have their own office
Oh,
space,
sure, sure.
right? That can
Mhm.
be perfectly set up to their own ergonomic needs. But for you and me and the nurses we work with, we're visitors in the operating room every single day in a shared space.
Hmm.
So the challenge then is it's all really on us as individuals
Correct.
to know about ergonomics, to have a practice, for it, and then to implement it daily.
Hmm. Hmm.
And there's no coaching or training or very little in that space. I mean, you're doing great work, Dr. Halle, Dr. Alam, one of my colleagues, an
Yeah.
anesthesiologist in Toronto here. But there's not a lot beyond that, as far as I know. Certainly, I don't recall ergonomics training in my training as a resident. So, changes I've made. Well, I've changed the way I practice entirely in terms of my day to day with ergonomics, and I can take you through step by step.
Please,
Uh,
let's do that. And I also
Sure.
want to know how you learned these ergonomic best practices, who you learned, because again, we don't really have too many ergonomists who are experts or are knowledgeable regarding sort of things in the OR.
That's right. And so fortunately, unfortunately, I learned through my physiotherapy and
Mhm.
occupational therapy that I was able to really focus on during my time off. I was 3 days a week for an hour each session. So it wasn't until I had the opportunity to really study my own occupation with a learned professional, like a physiotherapist or occupational therapist, and then and work through carefully. This is my posture when I intubate. This is what it should be. This is my posture and my approach to transferring patients. This is how I should be adjusting my monitors. This is how I should sit properly when I'm charting. I had to go through all of those individual aspects of my job with a professional to figure out how to do them ergonomically. And I can tell you, I was doing them all pretty much wrong. And I was just doing them how they came natural to me from the beginning. So that was the education component. And then there was the application component where when I returned to work, it was then building in a process whereby ergonomics just became automatic for me. So when I talk about my approach, it's going to sound like a lot. And who has time for all this in their day to day? But it's really as automatic now to me as brushing my teeth is. But that took time and education. And so without the education in a formal way, because we don't want anybody to have to go off work for a year to learn these things. So we need the education more upfront, ideally as a trainee, but it's never
Mhm.
too late either for someone in their career. And then you have to basically put it into practice and develop your own routine. So that's the way I look at that. But I could take you kind of through my approach, step by step if you'd like, and just jump in at any point if you want to.
Yeah. Yeah. So what I'll say is that, I agree with you 110%, Chris, that we shouldn't have to take a year off or time off to learn about how to set up our workspaces ergonomically. Ideally, it should have been included in our training, just like we're taught to take care of patients with patient safety in mind. This is a component of that. But you also, correctly stated that it's never too late. We can do the education piece moving forward, but you were able to learn just like I spent time learning what I could do differently to keep, my career in operating going until I chose to walk away from it. And so, yes, I think it's important if you can share specifically what you do, because I'm sure there are other anesthesia providers, trainees, and even surgeons listening to this podcast. And perhaps they can take this to the anesthesiologist that they work with, right? And kind of help disseminate this while we build those other things.
Perfect. Yeah, and I completely agree. I think that would be really helpful starting point for individuals, but you need to know what you don't know in order to kind of move
Exactly,
forward,
exactly.
right?
And we'll be back right after the short break. Surgeons and proceduralist colleagues, we train for years to master what we do, but most of us are never taught how to protect our bodies while doing our jobs. Neck pain, shoulder fatigue, back stiffness after long cases. For many of us, this isn't the exception, it's routine. I'm launching the first cohort of a virtual hybrid coaching program in surgical and procedural ergonomics, designed for clinicians who want to perform at a high level without sacrificing physical health or career longevity. The program includes 2 small group sessions plus 2 individualized one-on-one coaching sessions using PostChecker, which is an AI-based motion capture system that provides personalized, actionable ergonomic insights both inside and outside the OR. I'm Geeta Lal, an endocrine surgeon with over 2 decades in the operating room and first-hand experience with the pain that comes from operating. I'm joined in this endeavor by Linda Miller, an occupational therapist and certified professional ergonomist, and together we bring real-world OR-tested solutions to you. If you're ready to invest in your performance and your longevity, email me at geeta@surgicalergonomics.com to get details and register. Your body is not disposable. Your career shouldn't be either.
So I think step one really is just an umbrella theme, but it's advocating at your place of employment for a more standardized and ergonomic layout of your workspace. For us, the low-hanging fruit is the way the anesthesia cart is organized, the presence of adjustable equipment, monitors, your workstation, and your chair,
Hmm.
specifically. But you need certain equipment in order to have an ergonomic workstation, and not all operating rooms have those. So that's number one, and you can advocate for that either directly if you're in a position of administration, like as a medical director, or you can advocate directly to your medical director. But at Quinte Health, I was a medical director, and I had a back injury, and I had good relationships with my program director, and so I was able to just advocate for us. Principally, what we were missing was adjustable chairs, and it
Mm.
wasn't that large of a capital expense for the hospital to replace
Hmm.
our fleet of chairs, which at
Hmm.
the time didn't even have arms. There was no adjustable lumbar support. It was a rough situation, but a lot of operating rooms are in that situation. So number
Right.
one is just advocating for the right equipment. My daily process starts, I mean, as soon as I enter the operating room, this is the beginning of the day, but also after each case, I'm doing a quick environmental scan looking for hazards. And it happens automatically now, but there's so many hazards. There's wires everywhere. There's equipment to bump into. There's low-hanging equipment to literally knock yourself out on. Some operating rooms are in shambles after a busy night of call, or
Right.
just in between cases from the cleaning staff adjusting or moving things to clean underneath them.
Hmm.
So, the one of the main learnings that I have come to realize is you can never assume that your workstation is optimized for you when you walk into the operating room, because it's
Right.
dynamic. It's always changing.
Right.
So as I'm noting these hazards and correcting them in real time as I walk to my station, essentially. Very quick
Mhm.
process. And once you get good at it, it's easy and automatic. Then as I kind of get to my workstation, it's about your monitors and your equipment positioning. So the
Hmm.
person working there before you, their seat was going to be adjusted for their ergonomic needs, hopefully, but not
Hmm.
necessarily for yours. Our computer workstations, ideally, they're on a boom, so you can manually adjust them up or down. You want to make sure that it's adjusted properly. It's at your eye level, for example, not above or below. Same with your keyboard. You want it so it's at the proper level to maintain ergonomic position. The anesthesia machine itself, you want to make sure that it's positioned such that you're going to limit your twisting and turning during your induction of anesthesia. You should be able to see the monitor at the front of your anesthesia view, or at least just off to the side, not all the way to your right, which is kind of the standard
Standard.
setup, right?
Yeah.
You want to be able to ventilate the patient with the bag without having to over rotate your right arm and shoulder and twist your body while maintaining your seal. These are some
Right.
simple examples, but this is every case. Uh,
Exactly.
you know what I mean? So, and then you also want to declutter your space so you have room to move without unnecessary twisting and turning within that environment. So I'm not over exaggerating when I say that I manually reposition my anesthesia machine, my anesthesia cart, computer station, operating room table multiple times a day because they're moved multiple
Right.
times a day.
Right.
So those are the early steps, and then
Hmm.
you get into more specific parts of this where when it is time to induce an anesthetic, I need to make sure that the operating room table height is basically going to position the patient's head around my umbilicus.
Hmm.
That's going to allow me to manage their airway in an ergonomic position where I'm standing straight, my elbows are tucked in, I'm not having to reach forward and lean forward and stoop for the patient.
Hmm.
Also making sure the patient themselves is close to my body and
Right.
not down the bed. There are times where, for example, if it's a obese patient and I know they're going to be in lithotomy and they're going to need to be way down the bed, if I'm
Right.
just putting in an LMA or something straightforward, I may choose to have them further down the bed so we don't have to, as a team, then move them when they're asleep. But I'm not going to do that if I have to actually perform an intubation, for example, because to do that
Hmm.
from a stoop position is pretty taxing on the lumbar and cervical spine.
Right.
Patient positioning, OR table height. Again, I do teach this to my residents. This is something
Hmm.
that you really should be adjusting quickly before every patient interaction. And then, something you alluded to earlier was how risky patient transfers can be for members of the surgical team.
Hmm.
If you're at the head or the foot of the table, you're in a situation where you're going to be rotating your own body while under load. And that's really risky from a shear stress perspective on the lumbar spine. So I have lots of techniques for that. I mean, first and foremost, I'm never shy to enlist extra help. There's cleaners,
Yes.
there's nursing staff, there's surgical assists, there's lots of people, right? There's anesthesia assistants.
Yeah, don't carry it alone.
Exactly. I mean, I can remember being on call at night when my back was starting to bother me years ago, and there'd basically be three of us, transferring a 300 plus pound patient, and none of us weighed more than 150 pounds ourselves. And I remember thinking, did we ever think this was acceptable? So
Right.
enlisting help is important, and it might take an extra 20 seconds, but it's a really important part of this. But then there's the other things, using a high quality transfer roller board.
Right.
Like they're so important. I prefer the roller boards that are half length to the ones that are full length.
Yeah.
However, just having a roller board is a huge step in the right
Use,
direction.
yeah, use technology, right?
Absolutely.
Rather than person power.
Right. And actually on that same line, use gravity. I tilt my table all the time. I'll tilt my table to the right so to help with the either the nurse or the surgical assist who has to tilt the patient to get the roller board in. I'll tilt it a
Mhm.
bit to give them some gravity, and then I'll tilt it all the way back and beyond towards the stretcher we're moving the patient to help us move downhill, with
Yeah,
that part of it as well.
yeah.
And I mean that's a 1 or 2 second thing. Hold on, everybody, 1 sec. Here comes the tilt. You use the button,
Right.
and there you are. As an anesthetist during that process, I've learned to focus my efforts on the head and neck. I
Hmm.
used to actually really get under the shoulders and almost take control of the torso. It's just way too much weight in an adult patient to take on when you are going to then be rotating. I've come to realize that you're much better to use the roller board and gravity to really bear the brunt of the torso, and you just focus on the head and neck because the adult head and neck is still a fair amount of load for the lumbar spine. The last 2 points on patient transfers, one is actually, and I learned this from a physiotherapist, you need to move actually with the patient. I just learned to grab the head and shoulders and maybe the torso itself and just lean forward and rotate the patient over to the stretcher. But you actually need to move your feet while maintaining an upright ergonomic position during the transfer. And the trick to that is you have to first clear a path. You have to be intentional about clearing the path, because you think about the stretchers that you're moving the patient to, they have bed handles that are in your way. There's often an O2 tank that's projecting out into your area. There might be an IV pole standing. So you just have to quickly adjust all that, make a path, and now you can move with the patient. And honestly, I went from it not being uncommon to have tears in my eyes after a patient transfer to I don't even feel them anymore. It's not just because my back
Wow.
is improved. It's because the sheer stress I put on my back with the transfer now has gone from very high to almost negligible. And the final pearl to all that is you want to make sure you've put the patient stretcher out. You want to align it such that the patient's head is going to land at the top of the mattress. It's again, if we just assume that every time the person who brings the bed in is lining the bed up perfectly, we're in for some hard truths when we get to recovery, because the first thing the PACU nurse is going to do is say, hey, let's boost this patient, right? And so then you get to the recovery, and now you're doing another patient transfer, and that one's even worse because that one's usually just you and maybe one nurse very awkwardly trying to boost a patient up a bed who's still more or less dead weight. With that sort of an approach, which sounds like a lot, but again, once you make that your practice, it's automatic. It saves so much wear and tear on the body.
Right. Right.
Yeah, because that's the highest risk time. There's no doubt about it.
Yeah. No, Chris, thank you so much for sharing these very practical tips with the listeners of the podcast. And I want everyone to note these nuggets of gold, okay? For the surgeons and surgical trainees listening, or for the nurses listening, I want you to share this episode and these nuggets with your anesthesia colleagues, if at your earliest, I should say, so that they can start being, as Dr. Perkes has described, intentional, right? And it would go even a step further if it became part of a team sort of ergonomics timeout, just like we do a pre-incision timeout to check that we're operating on the right body part and the right side. And Dr. Perkes has said it really well. Once it becomes second nature, it takes 30 seconds, okay? And, sometimes we think, oh, I'm just going to move this patient. It's only going to take 15 seconds, right? But remember that twist in your spine, when you don't move your body along and didn't prepare your environment to do that, that twist multiplied by 7, 8 cases a day, multiplied by how many, weeks a month you do this, that is what repetitive strain injury is.
Yeah.
And, it's not just that, the onus shouldn't be on the surgeon to take care of their thing, the nurses to take care of their thing, and the anesthesiologist to take care of their thing. It should really be about the entire team. And so, it's not uncommon. Sometimes I'll see the poor resident, the attending is in 2 rooms and maybe the resident is trying to intubate the patient and they haven't elevated the bed. And I'll say, let me just elevate the bed for you. It looks like you're
Mhm.
struggling. Or I slide a step underneath, and I say, hey, why don't you stand on this step? I think you're going to have an easier time. So it doesn't matter, if it's not someone not, on your immediate team. I think we can all look out for each other as the team looking after the patient in the OR.
It's a great point, and I do find myself now with my life experiences
Right.
very commonly asking the surgeons, "Do you want the bed
Yes.
up? Do you want the bed down?" I mean, some know and they take control of their own ergonomic practice, but others either don't or their mind is elsewhere, which happens during stressful clinical situations. And as soon as I notice, that they're hinging at their hips or awkwardly straining, if there's something I can do to help with the position of the bed, I'm just offering now because, not only do I know what it can lead to, the harm and that, but there's also good evidence to suggest that if you're performing procedures with good ergonomic form, your
Hmm.
first class success is higher. So you're a more effective clinician when you're operating from and functioning from an ergonomically sound form. So you're not just helping your colleague or yourself, you're actually helping your patient. And
Right.
so, that's kind of the way I look at that. And you're right; it is a team approach as much as it is an individualized practice.
Right. Right. Thank you. So for the anesthesia providers, trainees included, who might be listening to this episode, I'm going to sort of suggest something because I think it comes from my personal experience and it sounds like Chris's personal experience as well. There aren't that many individuals, OTs, PTs, or ergonomists who are familiar with the OR environment, but you can help them by having someone take pictures of you at your job doing what you do, like intubating the patient, or videos. I mean, I'll just say I use video based ergonomics coaching. So if you just take those videos to someone that you're seeing for physical therapy, they will understand and then they will provide you with the tips that you need to protect your body. So, don't feel like, oh, this person doesn't know what I work like. Well, you can help them. I remember the aha moment, when I took pictures of myself in the OR to the physical therapist and they were like, yeah, okay, now I understand why you hurt and let's see what
Yeah.
we can do about it, right? So don't be shy to do that, number one. And number two, I'm going to come back to, this thing that Dr. Perkes and I talked about earlier. So these are what you have learned from Dr. Perkes are things you can do to protect yourself, which in the hierarchy of controls that ergonomists use is counted as PPE, right? So these are the things that you can do to protect yourself on a day-to-day basis. But really, what we need are what we call higher level interventions because these lower level interventions, they're easy to implement. As you've heard Chris say, it's low hanging fruit, it's low hanging fruit, but it relies too much on individual taking the initiative to do it, right? So we need higher level interventions, and Chris alluded to some of those, which is thinking with your surgical and procedural and medical director and nursing administration about how things could be set up. So that's ergonomics setup is the default, not something you have to think about.
Mhm.
Ergonomic equipment is the default. But I also want to ask, about another element of that kind of organizational piece or workflow piece. And how do you disseminate these good practices that you have just outlined for your colleagues, for your trainees? Is there any move within the specialty to come up with kind of formal curricula or have modules kind of in anesthesia training? What roles can our societies play in something like this?
I think the education component is where so to speak, the money is at. And I
Right.
think that there's multiple ways to approach that. I'm not sure that a lot is happening necessarily right now at the teaching center level when it as it relates to this being taught in real time. Although it does seem like there is some work being done by some of our colleagues who we mentioned earlier, which is very promising, yourself included. But
Hmm.
yeah, I mean, I think what we would need to see is we would need to see some sort of a very simple but formal curriculum in the resident training package where they can learn these ergonomic approaches, make them a part of how they work, and then carry them forward, most importantly, to their future students. And it wouldn't have to be anything more than a lecture or two, and then just some day-to-day coaching from their mentors, and they would get to where they need to be. But
Hmm.
for me, I envision whether it's one lecture or two lectures, just to kind of
Right.
lay the groundwork for what good ergonomic practice entails, that they can then reference for the rest of their training.
Hmm.
It would probably include grand rounds at your major teaching centers to kind of coach up your educators, but then
Hmm.
also grand rounds in the community to coach up our colleagues who are mid-career.
Hmm.
The idea of a white paper on the topic is a great idea as well. You mentioned that in our pre-podcast discussion, something that can be easily referenced as well. But I think that those are some of the ideas where the work's done. It's just a matter of getting it out there and having people aware of it and then practicing it. And then, as you mentioned, raising the awareness at the institutional level for what is important in terms of the equipment that we need and the standardization that we need of our workspaces in the hospitals and the out of hospital premises where we work.
Right, right. All good points. And we are just starting to do that, in the last few years with procedural ergonomics. And I think we're a little bit further ahead in surgery thanks to the society. But I think anesthesiology and our nursing colleagues aren't far behind. So I'm looking forward to sort of, all the work that, you mentioned, Dr. Halle and Dr. Alam and others, and you might be part of that timeout study as well, as we're defining the elements of an ergonomics timeout. So I'm looking forward to seeing what that work results in. And you're absolutely right. Sometimes I think that it'll just take one generation of trainees to change this and it will become, standard operating procedure. You shouldn't have to think about these things. It should just be automatic.
Absolutely, I
Yeah.
completely agree. The same way that we approach, infection control in our practice, or safe medication drawing and labeling and administration. Ergonomics could be right alongside those in terms of how automatic they are uh,
Right.
once they're taught, practiced, and institutionalized.
Right. Ultimately, it is, part and parcel of the care and safety of taking care of other people. So, Chris, I just noticed it's almost to the end of our time, and I just want to take a moment to again express my sincerest gratitude to you for taking the time out of your schedule and spending some time with me today to talk about ergonomics from an anesthesiology perspective. I know that my anesthesia colleagues were grateful when we all got anti-fatigue mats as well, not just for us surgeons, but for the nurses, and we would slide one under the anesthesiology sort of, where they're standing. And it's just, again, looking out for each other. So, my sincerest thanks to you for the work that you're doing and for being here today.
Thank you. Thank you as well to you because you are doing a lot more work than I am on this space, and I'm grateful for it, and I'm grateful for the opportunity to share in the work that you're doing.
Yeah, just like in the OR, it's teamwork. We're all doing
Yeah,
what we can. So
exactly. Yeah.
please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.